very good morning to one and all. This is Alisa, first year resident, going to talk about role of ectoin eye drops as an adjuvant in vernal keratoconjunctivitis, A New Hope. I do not have any financial interest to disclose. VKC is basically a bilateral atopic condition of the external ocular surface, mainly IgE mediated. There are several challenges while treating VKC. One such is the dry eye syndrome, which I'm going to talk about. Dry eye still remains an underdiagnosed complication of VKC, which compromises with the quality of life of these young minds. Here comes the role of a tear stabilizer and a noble molecule like ectoin, which is an extremolyte, which stabilizes the lipid layer of tear and hence prevents excessive evaporation of the tears. So my aim was to compare the result of loteprednol plus ectoin eye drops versus lote alone in the treatment of moderate to severe VKC. It was a tertiary-based prospective study in the spring months of March to May. Newly diagnosed cases of moderate to severe VKC with age more than 5 and less than 16 were included. Patients with any other stage of other ocular inflammatory disease, one-eyed patients, patients with history of surgery, trauma, and history of medications, and contact lens users were excluded. After taking informed consent, 40 children were grouped into two groups, with Group A receiving loteprednol with ectoin in the mentioned doses, and Group B was lote alone. We have followed up the patient with before the starting of the treatment, a week later and a month later, on total subjective symptom scores and total objective ocular sign score. TBUT and modified Bonini were degraded at the beginning and the end of the treatment. Tolerability in terms of history were taken at each visit and data was analyzed. These were the 5 symptoms, the 5 major, which were scored and graded from 0 to 3, 0 being the lowest and 3 being the highest. These are the 5 main signs that has been graded from again 0 to 3. These are some of the signs that I could find in my patients. Now coming to modified Bonini grading as such, where 0 refers to absence of symptoms and 4 is complete symptoms and signs. Coming to results, as you can see in both the groups, the age and the gender are matched, and Group A and Group B both have a male preponderance. In coming to symptoms again, over 0, 1, 2, and 3, week 0, 1, and 4, there has been a decrease in mean score of both the groups. By the end of 4th week, there has been a significant decrease in mean score of the symptoms, and it has come down from 8 to 1. The single most common symptom found was foreign body sensation followed by photophobia. In signs again, there has been a decrease over the 4 weeks and it has been significant. However, the symptoms have decreased more than the signs, and the most common sign was conjunctival hyperemia. In modified Bonini grading, as you can see, in Group A, because of a tear stabilizer that we had given, that 2 people could come down to symptom-free stage, and no such finding was seen in Group B. Coming to TBUT, there was encouraging results where in Group A, 12 people could come down to less than 10 mm to 2 people, and in Group B, it was 11 to 4. So summarizing my results, VKC was found more in males in both the groups consistent with the literature reviews. Foreign body sensation was the most common symptom. Conjunctival hyperemia was the most common sign. Both symptoms and sign improved statistically significantly in both the groups. However, symptoms mean score came down to 1 and was more significant. While taking history, tolerability in Group A was much better and encouraged them to take the treatment and accept it better. There was better result in improving TBUT levels, that was 80% versus 63%. And in the first group, like I mentioned, 10% of them could be symptom-free. Coming to conclusion, VKC has been a long-term burden since a long time on the society. So my effort was to include such a novel compound like ectoin, which can represent as a viable alternative or an add-on treatment to the standard treatment given and combat the challenges of dry eye and help with the burden. These were my limitations, that the sample size was small and there was a lack. We could have followed up the patients a little further. These are my references. I'd like to conclude. Thank you.
When was this ectoin discovered?
So it was around 3 years back. Like it started off with.
It was way back in 1985.
Oh,
so Jelinski and et al. Actually they have in.
How long you have followed the case?
Ma'am, for 1 month.
1 month.
4 weeks.
So what are the long-term complications of steroids?
Increase in there could be increase in IOP, and there could be cataract issues, could be steroid-reduced like glaucoma.
Only glaucoma?
With lote, there are chances cataract also can happen.
What type of cataracts?
Like posterior or subcaxillary.
So how long it take to develop secondary glaucoma or steroid-induced glaucoma or cataract?
It was around, like in the studies, they said with lote, the increase in IOP could come up after 55 days of use, and cataract it took longer, like over
What
6 months.
measures we have to take to prevent those complications while treating the patients with the steroids?
We could first give them in taper doses, and then we could ask them to come for regular checkup with IOP, increasing IOP if there is a increase in IOP. Because I followed it for.
You included loteprednol in both groups. How would you say this effect is due to only this drug? Already steroid effect is there now. How would you say?
Ma'am, my study was to show that we cannot replace lote. I'm not trying to replace the standard treatment. I'm just using it as an adjuvant so that the symptom part of the VKC that we do not focus on, the subjective improvement of symptom could happen because if we give a tear stabilizer.
It's like a only tear substitute.
It is, yeah. My point is to add it as a adjuvant so that the like symptom per se, which is a very difficult thing to deal with, comes down.
How it is better than other tear supplements?
Ma'am, the ectoin one, which was when it was taken up, as such in India there hasn't been only monotherapy of ectoin, so I couldn't use only ectoin drugs per se in India. That hasn't been marketed. So if at all it comes, I can take up this study further.
Thank you.
Call upon Ananya Hota, who is going to speak about correlation between vitamin D3 levels and dry eye disease.
A very good morning to everyone. I, Ananya, am going to present on the topic of correlation between vitamin D3 levels and dry eye disease. So I have no financial interest or conflict of interest. Dry eye is a prevalent disorder of the tear film resulting from either decreased tear production or increased tear evaporation. Tear film is a thin layer of fluid that coats the front of the eye and helps to keep it moist and comfortable. The symptoms of dry eye are stinging or burning sensation, watery eye, sandy or gritty feeling in eyes, episodes of blurred vision, and redness. Factors contributing to dry eye are aging, certain medications, medical conditions such as rheumatoid arthritis, Sjogren's syndrome, environmental factors such as wind, dust, and smoke, meibomian gland dysfunction, a condition that affects the oil glands in the eyelids. The purpose of my study is to investigate the prevalence of serum vitamin D3 level in patients with dry eye and its correlation with the severity of dry eye. It was a cross-sectional study was conducted in my hospital for a period of 6 months from January 2023 to June 2023. 60 patients were taken, out of which 40 had dry eye and 20 were controlled. The patient with dry eye were diagnosed based on the 3 criteria: the ocular surface disease index score, Schimmer's test result of less than 10 mm in 5 minutes, and tear film breakup time of less than 10 seconds. The control were healthy individual with no symptoms of dry eye. All participants were given serum vitamin D3 level of laboratory test. The prevalence of vitamin D3 was then correlated with dry eye and its severity. As we can see here, there is no gender predilection. The study found that the serum vitamin D3 levels was more prevalent in patient with dry eye than in control. There was no gender or age predilection. Vitamin D3 level was negatively correlated with OSDI and positively with Schimmer's test 1 and 2 and tear film breakup time score. However, the prevalence of vitamin D3 level was not consistently found to be associated with the severity of dry eye. The result of this study suggests that vitamin D3 level may be a risk factor for dry eye, but the relationship between vitamin D3 level and severity of the dry eye is not clear. In this result, we can see the comparison between the control group and the test group in all the 3 tests, the Schimmer 1, 2, and the TBUT. Coming to this graph, here we see the vitamin D3 level distribution in both the control group and the test group, where we can see the mean in the test group is significantly lower than in the control group. And in the second graph in this page, we can see the vitamin D3 is related with dry eye, but not consistently related. Conclusion: in our study, vitamin D3 level was found to be more prevalent among patients with dry eye than patients who did not have dry eye, indicating a possible association between vitamin D3 deficiency and dry eye. However, serum vitamin D3 level were not consistent. The possibility of vitamin D3 deficiency as an etiological factor for dry eye and the therapeutic effect of vitamin D3 supplementation in dry eye disease need to be further explored with a larger sample study. OSDI index can be utilized as a reliable tool to diagnose dry eye, as it was consistent with subjective findings of dry eyes. Discussion: the result of the study are consistent with the finding of other studies. The exact mechanism by which vitamin D3 deficiency contributes to dry eye is not fully understood. However, it is thought that vitamin D may play a role in the production of tears and maintenance of the tear film. Vitamin D also have anti-inflammatory properties which may help to reduce inflammation in the eye that can contribute to dry eye. More research is needed to better understanding the role of vitamin D in dry eye and to develop effective treatment strategies. In the meantime, patients with dry eye may want to consider getting their vitamin D3 level checked and taking vitamin D supplementation if they are deficient. The limitation of my study was it was a small study sample, and by the virtue of being a cross-sectional study, no follow-up was taken nor any intervention was done. The therapeutic effectiveness of vitamin D3 supplementation cannot be commented upon to establish a causal association. Thank you.
What's the normal D3 level?
So it should be more than 20 nanogram per ml.
Found out actually there is a cutoff point where actually these people they are developing the dry eye.
Yes, sir, if they're less than 12 to 15,
How will you manage vitamin D3 deficiency?
ma'am, we have to give supplementation.
How much? What is the daily dose? How many days we have to give? Weekly once.
What are the previous studies which were done on this topic? The RCTs or cross-sectional? There were many studies in India. We don't have it here. So what is the pathogenesis of serum vitamin D3 in dry eye? What is the pathogenesis of deficiency of serum vitamin D3 in dry eye?
Thank you. Next, I call upon Sobhana Rath, who is going to speak about myopia, tip of iceberg in post-COVID era.
Morning everyone. Today my topic of discussion is myopia, the tip of iceberg in post-COVID era. There is no financial disclosure. As we all know, myopia is a refractive error in which the rays of incident light are focused from infinity in front of the retina in an unaccommodated state. Burden of myopia has significantly increased post the COVID-19 pandemic. Though the COVID-19 pandemic has been long been over, yet we are seeing significant cases in young children who are being newly diagnosed with myopia. The digital platform or online teaching is still being continued in the schools, though the pandemic is over. The school-going children in the vulnerable age group of 6 to 10 years are still being diagnosed with new onset myopia, attributed by the exposure to longer screen time, lower outdoor activity, and excessive near work. Why are we so much concerned about myopia? Because myopia is a refractive error which comes with its own set of dreaded complications. So the aim of my study was to detect the onset of myopia in school-going children aged 6 to 10 years. We did a cross-sectional study including 110 school-going children from the age between 6 to 10 years of age, conducted between January 2023 to March 2023. We took a proper history about the hours spent on the screen, type of screen they used, and for the purpose they used the screen, like for educational purpose or for recreational purpose or for both. And the hours spent in outdoor activity was also noted. We measured the uncorrected distance visual acuity, the cycloplegic refraction was done, and then the best corrected visual acuity was noted. We included the school-going children between age 6 to 10 years who presented to our OPD and children who were able to read the visual acuity charts. We excluded children who were less than 6 years of age and more than 10 years of age, previously diagnosed cases of myopia and who had a history of other refractive errors and any other ocular pathology, ocular trauma and surgery, and guardians who did not give consent to participate in the study were included in the exclusion criteria. We took a detailed history about the hours spent on watching digital screen, and when we took a history we found out that 72.72% of the kids, they used the digital screen for more than 4 hours in a day, and less than 1 hour was being used by only 27.28% of cases. The type of digital screen used most commonly was the smartphone, which was like 81.81%. Purpose of use of digital screen was for 100%, it was being used for educational purpose, and for educational purpose and recreational purpose it was being used by 77.27% of kids. The hours they spent in outdoor activity was less than 1 hour in 80% of cases, and greater than 1 hour was noted in only 20% of cases. When we recorded the visual acuity using a Snellen's visual acuity chart, we found out that 47.27% of cases had it between 3/60 to 6/60 in the right eye, 31.80% had it between 6/36 to 6/12, and 11.81% had it between 6/12 to 6/9 in the right eye, whereas it was only 43.63% in the range of 3/60 to 6/60, 46.36% in the range of 6/36 to 6/12, and 10% in cases of in the left eye between 6/12 to 6/9. A cycloplegic refraction was done, and when the best corrected visual acuity was noted, we found out that it was between 6/24 to 6/12, 6/12 to 6/9, and 6/9 and 6/6 in 50% of cases in right eye, and 27.27% had it between 6/12 to 6/9 in left eye. The number of males and females which we included in the study, we found out that 59.09% were females and 40.9% were males. And interestingly, we found out a seasonal trend associated with this. Most of the cases presented to the OPD in the month of January, and probably this was because the early onset of evening and lesser outdoor activity during that time. So 68.66% presented to us in the month of January, and whereas it declined to 12.6% in the month of March. When we interpreted the results, we found out that the average duration of use of digital devices in 24 hours was 4.583, and the p-value was found out to be 0.044, which was found to be statistically significant, and the females were diagnosed to have myopia attributed to the lesser outdoor activity amongst the females as compared to their male counterparts. So in our study, we found out that 4.583 hours was the average duration of digital device used in 24 hours, and effective outdoor time was found out to be less than 1 hour in 24 hours. So to conclude, I can say that school-going children are our assets, so proper parental counseling is a must, and traditional blackboard and chalk method would probably a better method of teaching than the online method. And the take-home message, I would say that less time of being online can give us a good eye timeline. These are my references. Thank you.
How do you think this COVID has influenced the myopia? Has it got any relation, COVID and myopia?
This maximum use of digital screen after the pandemic, every mode of teaching was converted to the digital platform only. So in our OPDs, we found that most of the school-going kids, they used to come to us with this complaint of blurring of vision. And when we did a refractive, when we went for this PMT refraction, we found out that most of them were diagnosed with myopia. And this diminution of vision complaint, maximum kids, they came with this complaint after this COVID only. And that pandemic has been over, but till now they are coming with this complaint.
You mean to say that prior to COVID they were not myopes?
There was myopia, but in our hospital also, when we looked at the statistics, we found out that last year January to March, and this year January to March, when I conducted this study, there was a 2/3 increase in the number of kids who were diagnosed with myopia.
Is it related to screen time or lack of outdoor activity?
Both are actually associated with. The more the kids who were more using the digital screen like more than 4 hours in a day and had a lesser outdoor activity, they were diagnosed with myopia mostly.
Have you studied vitamin D levels? You had to correlate vitamin D levels also.
Yes,
There
it
are
is
studies
related.
regarding myopia in vitamin D deficiency patients. and you have to do studies in school screening camps. Okay, OPD is not enough. Nice.
Three, a survey of blind schools in Western Odisha. Has she come? Lihalin Chaudhary. Okay. The next, Akshita Dhoni, a study on visual disability certificate.
I'm here to present paper on a study on pattern of blindness in pediatric patients seeking visual disability certificate. Financial disclosure, no conflict of interest. Coming to introduction, blindness remains to be a highly prevalent and serious health problem in many countries. India was the first country in the world to launch a 100% public funded program for the control of blindness. According to WHO definition, visual acuity of less than 20 by 400 or less than 3 by 60 and or a visual field of no more than 10 degree around the central point of fixation in the better eye is the definition. And coming to certification in India, registration as blind or low vision is voluntary and it is certified by an ophthalmologist. The minimum degree of disability should be 40% for an individual to be eligible for visual disability certificate, which is according to the guidelines of Ministry of Social Health and Empowerment, Government of India. This is the percentage of visual disability followed in India. My aims and objectives of the study is to identify various causes of blindness among pediatric patients seeking visual disability certificate in a tertiary care hospital, Visakhapatnam, and categorization or giving percentage of disability as per the Persons with Disability Act 1995 and guidelines given by the Ministry of Social Justice and Empowerment, Government of India. Coming to materials and methods, this study is a hospital-based retrospective study done in between January to August 2023 in the Department of Ophthalmology, Government Regional Eye Hospital, Visakhapatnam, taking 50 patients. My inclusion criteria is pediatric patients less than 16 years attending ophthalmology OPD, Government Regional Eye Hospital, Visakhapatnam for visual disability certificate. Exclusion criteria includes patients with temporary causes of visual blindness and one-eyed patients. Patients were subjected to a detailed history of ocular condition and its duration, detailed family history, systemic diseases, medications were all noted, and the clinical examination of the patient included a general physical examination, systemic and ocular examination. Visual acuity is recorded. Slit lamp biomicroscopy of anterior segment and detailed posterior segment evaluation was done. B-scan was done in cases where posterior segment evaluation was not possible due to hazy media or any pathology. Visual field testing were done in cases of retinitis pigmentosa. MRI CT were done for patient only if required, and a standard clinical proforma was used. Data on various causes of blindness, percentage of disability, gender distribution was assessed. Coming to results, out of 50 patients, 33 were male, accounted for 66%, and 17 were female, accounted for 34%. And coming to the causes of visual disability, 29% were coming under retinitis pigmentosa. Second most common cause was congenital anomalies in my study. Third was optic atrophy and other retinal pathologies. Coming to the percentage of visual disability, 37% of patients were given 40% visual disability, 20% of patients were given 75% visual disability, and 43% patients were given 100% disability. Coming to discussion, in my study, leading causes of visual handicap in the study were retinitis pigmentosa, accounting for 29%. Second most common was congenital anomalies of eye, accounted for 14%. Other causes were optic atrophy, retinal pathologies like ROP and retinal detachment, corneal pathology, amblyopia, pathological myopia. Avoidable blindness accounted for 42% and non-avoidable form was 58%. This is the percentage of visual disability in different studies. These are the causes of visual disability in various studies. And one limitation of this study is that it's a hospital-based study and the data regarding various causes of blindness cannot be directly compared to the data from the field surveys. Coming to conclusion, results in this study showed a higher number of cases of retinitis pigmentosa and congenital anomalies, which explains the necessity for genetical counseling, and avoidable causes, both preventive and curative, of visual handicap were found in individuals who were with phthisis, corneal opacity, and corneal retinal detachment. Screening, early diagnosis, and treatment is critical to prevent blindness from avoidable causes like retinopathy of prematurity, and creating vigilance about avoiding trauma to eyes by proper safety measures is needed. School children screening is a must to identify and treat refractive errors in childhood, and benefits provided via visual disability certificate and encouraging low vision aids and braille classes for education can play a pivotal role in rehabilitation of such patients. These are my references. Thank you.
What are the causes of avoidable blindness? What type of genetic counseling you want to give?
Retinitis pigmentosa, most commonly it could be autosomal recessive or autosomal dominant, ma'am. In such cases, if parents have the same gene, we'll tell the parents not to marry if both have autosomal recessive.
Marry at the same lineage or with children,
Not
so they can
to.
as well adopt.
Yes.
So what's the youngest child you have seen with retinitis pigmentosa?
8-year-old, sir. And she had 6/6 vision, sir, but we have done visual field testing for her, sir. Their only central vision was there, sir. So 6/6 vision is there. But only stage 2.
You did not go and
How many ROP patients you've seen?
Deepti P, comparison of psychosocial and emotional impact of childhood strabismus in a parent versus patient.
Good morning everyone. Presenting a paper on comparison of psychosocial and emotional impact of childhood strabismus in a parent versus patient. We know that strabismus affects any child in two ways: functionally resulting in amblyopia, psychosocially causing various emotional and psychiatric upheavals in the child. Despite so many impacts, yet there is a delayed diagnosis and the treatment noted in Indian subcontinent and has been published also. This has been attributed to knowledge, attitude and practice difference between the parents and the patients having strabismus. In this study, we compared this perceptual difference between the parents and the patients and evaluated what were the various barriers in the parents which resulted in delayed treatment and diagnosis. Was a prospective comparative study including 191 patients with strabismus and their parents. Any other coexisting pathology or poor comprehension of the questionnaire became an exclusion criteria. We studied patients and parents of all the strabismus which presented to us in the and we subjected them to pediatric adaptation of adult strabismus 20 questionnaire. The first 10 questions, as been shown in the 10 red color, has been assessing the psychosocial impact of the strabismus on the child. The 11th to 20th question has been assessing the functional impact of the strabismus on the child, and both these were modified to for both child as well as for the parents. They answered in the form of yes or no, followed by which a statistical analysis by using a Mann-Whitney test or independent t-test was done. Nearly 47% were in the range of 10 to 13 years, and exotropia was the most common type of strabismus in our results. Most of the children were from semi-urban background. So when we compared the psychosocial subscale of between the parents and the patients, we noted nearly 97% of the children did say us that there is a psychosocial impact of the strabismus in their life, but only 50% of the parents agreed to this aspect of the strabismus. This one question was the only point where both parents and the patient said yes, and if we go back and see, that is the 7th question: is the squint causing a cosmetic stigma? So this shows that the parents just perceive the squint as a cosmetic stigma in the child. The other emotional and the psychosocial aspects were neglected. But in contrast, when we assess the functional subscale, we noted that both parents and patients accepted, yes, squint causes a functional abnormality. It does affect my child's reading writing skills, the exam performance of my child, and my child is going back in the playtime because of the squint. Despite this agreement, what are the various barriers what the patients face? It is either belief related, where the child parents believe that this is a good luck charm. 34% of the parents said. The rest of the parents said this, it's just a cross eye. How is it going to affect my child? Or I can get it treated when my child becomes 18 years of age. The more the educated parents, there were misinformation because of the social media in 23% of individuals, where they believe that surgery can cause damage to the child's eye or repeat surgeries may be needed to treat the strabismus. So there are multiple studies in 2002-2003 which says that there is a deficiency of knowledge, attitude and practice among the parents towards the children with strabismus. This study has been done 20 years down the lane. Has anything changed? Yes. 76% of the parents now have a knowledge that squint does affect the functional impact of the child, and there is a management aspect which is available in various institutions. But still, there is a huge gap in the perception of the psychosocial aspect of the strabismus between the parents and the child. Child says yes, parent says no. I'm coming to the management. The social media is now playing a major role. In the rural background, the beliefs are still a major barrier for seeking strabismus treatment, resulting in intractable amblyopia. The prevalence of strabismus in India is about 7.4 per 1,000. So we need to definitely bridge this gap between the patients and the parents' perception of the strabismus. There is a need for awareness programs, changing the myths of the parents, and a perfect counseling when any child or the parent presents to our OPD, so that we can prevent this blindness of an amblyopia which we result because of the unmanagement of the strabismus. These are my references. Thank you.
Questionnaires are you prepared?
No, ma'am. This is a modified the adult AS questionnaire which has been used by Hart in 2009, and now that has been used as a WHO quality of life assessment questionnaire for any child which has been suffering from the strabismus to assess the avoidable blindness in them.
Your age group is?
6 to 16 years. We did try in 5 years, 4, but then the parents started to put a bias on the child. Hey, do illa, this is no, this is yes. So the child got biased by the parents' input. So we thought we will take those children who don't need the parents' help to fill up this questionnaire, and that came somewhere around 6 to 16 years of age.
Thank you. Good.
Thank you, ma'am. Thank you, sir.
Dr. Charu, manifestations of hypertension, its incidence and management.
Good morning, everyone. My topic is ocular manifestation of hypertension, its incidence and its management. There is no financial interest. Hypertension is one of the common risk factor of ocular disease like retinal vein occlusion, anterior ischemic optic neuropathy, retinal arterial macroaneurysm and retinal ambuli. Frequent fundus examination is very essential part of the examination in all the hypertensive patients. Various ocular symptoms noted in the hypertensive patients like blurring of vision, sudden loss of vision, amaurosis fugax and redness. The objective of this study was to study the incidence of various ocular manifestation of hypertension to manage the ocular manifestation of the hypertension. It is a prospective observational study of 6 months conducted in our OPD of our department. Inclusion criteria was the patient were above 30 years of age and patients who have been diagnosed with hypertension. The blood pressure was taken more than 130 by 90 mmHg, measured in two or more visits. Measured on 2 or more visits. Patients consenting for the study. Exclusion criteria was patient less than 30 years, patient with associated diabetes mellitus, patient with normal BP and patient who do not consent for the study. 150 patients were presented in our clinic and their details were taken and managed based on their clinical condition. On observation, we have seen male were more than the female. Male were 91% and female were 59%. On the age group, we have seen 50 to 60 years of both male and female were affected. In ocular manifestation, we have seen BRVO was 25, CRVO was 16, CRA was 4, NIN is 2, grade 1 hypertensive retinopathy 30, grade 2 33, grade 3 was 21, grade 4 3, vitreous hemorrhage was seen in 4 and CSR was in 2. Then we have seen that the hypertensive retinopathy was more seen in the limit of 140 to 150 mmHg, whereas others were The classification used was Keith-Wagner classification, mild to moderate narrowing or the sclerosis of the arterioles. Moderate second group 2 is moderate to marked narrowing, and group 3 is retinal artery narrowing and focal constriction as the group, and group 4 is group 3 plus papilloedema. These are the images. Psych classification was taken. This is hypertension. Grade 0 is no changes. Grade 1 is barely detectable arterial narrowing. Grade 2 is obvious arterial narrowing with focal irregularities. Grade 3 is grade 2 plus retinal hemorrhages, and grade 4 is grade 3 plus papilloedema. Arterial sclerosis, grade 0 is normal. Grade 1 is barely detectable light reflex changes. Grade 2 is obvious increased light reflex changes. Grade 3 is copper wire arterioles, and grade 4 is silver wire arterioles. Ophthalmic vascular changes may be a warning sign of the organ damage associated with the hypertension. Ophthalmologists play an important role in diagnosing and managing the hypertensive patient. All the patients in our study were referred to the cardiologist for the cardiac evaluation. Hypertensive heart disease was noted in 10% of our patients. 4% of the patients were presented after angioplasty with blurred vision due to acute vascular occlusion, and 3% patient after CABG with ocular problems like sudden loss of vision, and remaining 3% has ischemic heart disease. Retinal vein occlusion, second most common cause of retinal vascular disease after diabetic retinopathy. Atherosclerosis and hypertensive changes cause endothelial dysfunction and thrombocytic activation, leading to branch retinal vein occlusion. Patient underwent FFA and OCT to study the perfusion status of the retina and macula. Patients were explained regarding the prognosis and tried anti-VEGF injections. 2 patients showed improvement in visual acuity of 1 line, whereas other 4 patients did not show any response at the stage. CRVO also managed with the anti-VEGF injections. In ischemic CRVO presented with the multiple cotton wool spots and massive macular edema. Response of anti-VEGF in the ischemic vascular occlusion is limited. Clinically, we need to differentiate anion from the malignant hypertensive retinopathy properly to manage. Then impaired circulation in the choroid can cause CSCR as a complication of hypertensive retinopathy. Hypertensive choroid vasculature is more vulnerable for the systemic changes in CSCR than normotensive CSCR. Retinal and choroidal changes that occur due to the continuous elevated BP be resolved within the short period of time following BP control. They can lead to visual. The conclusion of this study is hypertension is a serious systemic disorder which can damage any organ in the human body. Need to evaluate and manage properly to prevent the major vascular disorder. Young patients were. Thank you so much. These are my references.
Your paper is on ocular manifestations. Yes, what inference we get on examining the AV crossing changes?
We can get that AV crosses from AV crossing changes, but how much hypertensive retinopathy the patient has developed. So accordingly, do they need they need to control the blood pressure as well as how much blurring of vision is there. If they are ready for anti-VEGF injection, we can give them.
How can you prevent end organ damage while treating a case of hypertensive retinopathy?
You have ruled out heart disease, but the main important CKD, chronic kidney disease, also should be ruled out, especially CRVO cases. Did you rule out any kidney disease in that?
There was one patient, but we didn't focus at that. There were patients, but we just ruled out the heart disease patient.
Have you treated any CRAO patient? I think 2 CRAO patients in your test.
No, ma'am.
What treatment to be given? When did they present? How many hours of defective vision?
She's going to speak about association between low serum vitamin D levels and axial length causing myopia in school children. I think
Is on association between low vitamin D serum levels and axial length causing myopia in school children. It's not. Introduction. WHO estimation in 2010, Vision 2020, Global Initiative for the Elimination of Avoidable Blindness 2020. Commonest factor among the visually impaired persons is refractive errors after the cataract. It's not
1 minute, the time has not started. It's not moved.
The slides aren't moving, ma'am. No, ma'am. Population-based studies, 30% of the world is currently myopic. By 2050, almost 50% will be myopic. That's a staggering 5 billion people. In India, myopia prevalence is 40 to 30%. Myopia can be corrected, but etiological evaluation to adopt preventive measures is urgent from a public health perspective. The etiological factors are many, but one of those from the recent studies is low vitamin D levels. Although India is in tropical zone and despite of abundance of vitamin D, 75% of the Indian population are suffering from vitamin D deficiency. Although the mechanism of reduced myopia risk isn't known, one possible explanation is vitamin D is known to influence dopamine metabolism. Hence, it is a possibility that increased vitamin D serum levels increase dopamine secretion, which is known to influence the axial length, change via effect on gap junctions and receptive fields, and limit the growth of eyeball beyond its limits. The major contribution is from the sunlight for the vitamin D. Aims and objectives to know and evaluate the association between serum vitamin D levels and axial length leading to myopia in 6 to 8 years school-going children. Time spent outdoors, indoors, and BMI is taken into consideration. Materials and methods. It's a cross-sectional study with 100 children. Study period August 23. Inclusion criteria 6 to 8 years old from nearby schools of Kandakuru Area Hospital. Exclusion criteria those with anterior and posterior chamber abnormalities and other types of myopia are excluded. Taken informed consent from the parents. Methodology: visual acuity, detailed history and ocular examination, axial length, cycloplegic refraction, myopia of all grades is taken into consideration. Blood samples for vitamin D levels and BMI or calculator. Questionnaire from the mothers is taken for the time spent outdoors and indoors for 0 to 5 hours. Results: a total of 100 school children were taken for ocular examination for myopia and laboratory testing for serum vitamin D. Girls had smaller axial length and boys that shows no result for the myopia occurrence, no sex predilection. The answers was taken from mothers. Children who stayed longer hours indoors watching mobile and TV had higher BMI. Myopia incidence is also more in them. Out of 100 kids, 49% are girls, 51% are boys. Of this, 20 of 49 girls counting 41% are myopic and 22 of 51 boys counting to 43.1% are myopic, showing no sex preponderance. In both genders, the axial length showed an inverse linear association with the level of serum vitamin D. That's a mean axial length is in the inverse relationship with the vitamin D levels. This is the time spent outdoors and the BMI for the myopes and non-myopes. Here the time spent indoors is same equal for the myopes and non-myopes. In non-myopes, the increased axial length is seen in few members, like 12 members, and more of the myopes have the increased axial length. This is in relation to the vitamin D levels. Of them, 10 are deficient of vitamin D, and 13 are having optimal levels in myopes, and 7 are having deficiency, and 26 are having optimal D levels. The odds of children being myopia with low vitamin D is 0.58, while being non-myopic is 0.41. The odds of children being myopic with optimal levels of vitamin D is 0.3, while being non-myopic is 0.66. Discussion: in young children, the axial length is inversely proportional to the vitamin D levels. 5 of 13 myopes have optimal vitamin D levels. Longer axial length is consistent with the answers given by the mothers. 4 of 26 non-myopes with optimal D levels have axial length, which is inconsistent with the study. In my study, only 12% of non-myopes have vitamin D deficient. Half of the non-myopes are having optimal levels. A study on a Korean population who have a high prevalence of hypovitaminosis D like India showed a high risk of myopia. A meta-analysis by Tang et al. Showed that lower vitamin D concentrations were associated with a high risk of myopia. However, they also inferred that the risk was more measurable in adults, was not significant in children. Our study have gender equal sex distribution as that of J. epidemiol, who concluded that there is no gender preponderance in vitamin D, causing myopia and odds ratio 0.65, similar to our study. Jones, Jordan et al. Prospective study, sports and outdoor activities were decreased in myopia subject 3 years before onset, thus pointing to a causal relationship between outdoor and myopia development. Strength is that myopes and non-myopes spend more or less time indoors. One drawback is sample size. Engage of the study population is a strength as well as drawback. Conclusion, it's an inversely proportional, and the suggestions are we need to encourage the children to be on the outdoors for more time with encouraging yoga and Surya Namaskarams outside with the direct sun exposure. These are my references. Thank you.
So next, Smriti Priyadarshnikar, analysis of efficacy of alfactidin, olopatadin, and beptostatin in allergic conjunctivitis.
Good morning, everyone. I'm Dr. Smriti, going to present on the topic analysis of efficacy of alcaftadin, olopatadin, and beptostatin in allergic conjunctivitis. Coming to the introduction, allergic conjunctivitis is an inflammatory disease that is predominantly IgE-mediated type 1 hypersensitivity reaction, where there is increase in histamine leading to activation of both H1 and H2 types of histamine receptors. So these are the pharmacological treatment of allergic conjunctivitis, which includes H1 receptor blockade, mast cell stabilization, and blocking of cytokine production and prostaglandin formation. So olopatadin hydrochloride, it is a selective histamine H1 receptor antagonist and mast cell stabilizer, which is also anti-inflammatory effects, which include suppression of interleukin 6 and 8 production. Alcaftadin is an inverse agonist effects on H1, H2 and H4 receptors. Beptostatin bacillate 1.5%, it has an antihistaminic activity with mast cell stabilizing properties. This study is randomized prospective parallel group study in which total ocular symptom scoring system TOS scoring was used. All patients aged between 18 to 60 years were taken in between July 2022 to December 2022. Exclusions: patients with severe allergic conjunctivitis, topical steroids or topical immunosuppressive agents, contact lens wearers, IOP more than 21 millimeter mercury, hypersensitivity to the study medications, ocular herpetic infection or any kind of active ocular infection, patients with steroids, antihistaminics, and pregnant ladies were excluded. So total 180 patients were taken in 1:1:1 ratio, having mild or moderate allergic conjunctivitis. Group 1 was given topical 0.25% alcaftadin OD. Group 2 was given topical 0.2% olopatadin eye drops OD. Group 3 was given topical 1.5% beptostatin bacillate eye drops twice a day. So total 200 patients were assessed, out of which 180 patients were taken into consideration after exclusion, and these 180 patients were divided into 3 groups: Group A, Group B, Group C. Group A was given alcaftadine, Group B olopatadine, Group C was given biptostatin. Then demographic data, medical history, concomitant medications, physical examination, clinical examination, vital signs, relevant blood investigations all were recorded along with the ophthalmological examinations. Then follow visits were taken on 3rd, 7th and 14th days. Then TOS score was recorded. Relevant laboratory investigations were repeated at 12 weeks. So after complete general examination, TOS score, demographic data, follow visit was taken on day 3, 7 and 14, and the patients with relapse, they were asked to visit on day 21. So this is the TOS score. So this is the TOS score and this is the hyperemia score. So this was the result which was found. The 4 major complaints were itching, redness, tearing and swelling. So early relief of allergic conjunctivitis symptoms was shown by biptostatin compared to alcaftadine and olopatadine. So by a comparative study by Dudeja, it was seen that all the 3 drugs were safe and well tolerated. So these are the results from different studies. So my strengths was randomization blinding of the patients, evidence-based option which was safe and effective, and limitations was that it was a single-centered, so comparison of efficacy and safety of study medications could not be studied. So coming to the conclusion, biptostatin, bacilit and alcaftadine groups appears to be better than the olopatadine group in reducing symptoms of allergic conjunctivitis. Thank you.
Next, Virendra Gaud, incidence of eye disease in rural and tribal population in Narsipatnam during DRP. What is DRP?
District Residency Program. So good morning everyone. I'm Dr. Virendra and I'm here to present my paper on incidence of eye diseases in rural and tribal population in Narsipatnam during district residency program. There is no financial interest in this study. Access to quality healthcare is a fundamental right, yet many rural communities face significant challenges in obtaining necessary medical services. Among the crucial healthcare services often overlooked in rural and tribal areas are the eye examination and the early detection of eye diseases. India rural population for 2021 was 96.8 crores and tribal people constitute 8.6% of the India's population, which is about 10.4 crores. Rural communities often encounter unique challenges when it comes to eye examination and eye disease management. Some of the key obstacles include limited availability of eye care facilities, distance and transportation, and socio-economic factors. My objective is to shed light to ascertain the importance of eye examination and incidence of eye diseases in rural and tribal areas in Narsipatnam during district residency program, and to explore the screening methods and to create awareness for periodical eye examination, to categorize the subject based on various ocular diseases. This is a hospital-based analytical observational study conducted in 154 patients for a period of 3 months, which is from March 2023 to May 2023 in Area Hospital, Narsipatnam. All the subjects underwent comprehensive ophthalmic examination where visual acuity, automated refraction, subjective verification were done, intraocular pressure was recorded by applanation tonometry, anterior segment and detailed fundus examination were done with slit lamp and 78D lens. All the patients attending the ophthalmology OPD in Area Hospital, Narsipatnam were included in this study. Patients under the age of 7 years of age were excluded and patients who did not give consent were excluded from this study. Results among the population of 154 which have taken in my sample, there are more amount of rural population which accounted for 74.02%. And this is the age distribution chart showing majority were in the age group more than 45 years, which is 51.94%, followed by 21 to 45 years age group, which is 33.11%. This is the sex distribution showing more amount of males in this study, which is 51.94%. And this is the frequency of ocular diseases, in which the cataracts, lenticular diseases were the most frequented ocular disease, which is 34.41%, followed by refractive errors, which is 26.62%, followed by conjunctival diseases, retinal diseases, glaucoma, corneal diseases, and adnexal pathology. In our study, the most frequented ocular disease is the cataracts, which is 34.41%. The following studies also have cataract as the most frequent ocular disease. The Pooja HV et al. Conducted a hospital-based cross-sectional study from July 2018 to June 2019 in patients more than 40 to 80 years amongst 2,912 subjects, in which males were more in the study and the cataract was most frequent disease. According to the APEDS, which is Andhra Pradesh Eye Disease Study, which was a population-based study conducted to determine the prevalence and causes of blindness and visual impairment in 11,786 subjects by multi-stage sampling belonging to urban, rural, and tribal population in Andhra Pradesh, cataract and refractive error were responsible for 60.3% of blindness and 85.7% of moderate visual impairment. Praveen Vashist et al. Conducted a population-based study in 2022 in persons aged 50 years above and concluded that cataract was the most common. Few studies showed other ocular disease as more frequent in the population, such as Anupama Kumar et al. Conducted a community-based cross-sectional study in 2016 in 812 subjects. Among them, the males constitute 51.4% and myopia was more common, followed by cataract. V.K. Schrodt et al. Also conducted a community-based cross-sectional study in 2005 in 925 subjects and concluded myopia was more common, followed by conjunctival xerosis, hypermetropia, pterygium, and cataract. To conclude, as the specialist medical services are scanty in rural and tribal areas in India, there is a need to conduct more screening and awareness camp to combat the avoidable blindness. By emphasis on education, we can bridge the gap and improve the eye health outcome for rural communities, enabling a brighter future for their residents. This can be done with trained paramedical assistants, and by teleophthalmic services, we can make significant progress in ensuring equitable eye care services for all. Campaigns for public awareness regarding surgical correction for cataract and correction for refractive errors should be strengthened. These are my references. Thank you.
You have not mentioned about corneal infections or corneal problems.
I have grouped under corneal diseases, ma'am, those all.
So what is the incidence of corneal diseases? At rural level, how are you managing the corneal infections?
If there are any ulcers, we are giving the antibiotic for bacterial ulcers and fungal ulcers. Natamycin is available there, ma'am, antifungals. If the ulcer has perforated, or we are referring to the higher centers, ma'am.
After perforation, you are
Not
referring
only
to?
after perforation, ma'am. If the ulcer is not healing also, we are sending it to higher centers.
How will you prevent perforation of corneal ulcer?
So we prescribe them antibiotics for any, we prescribe them the antifungals and antibiotics, and we prevent.
When you said cataract,
Sure.
Did you consider all the cataracts, or was there any cutoff line like
No,
6/9 or 6/12?
Not based on the visual acuity, sir. Immature, mature, everything we have taken in the cataract section, sir.
So you have gone to Narsipatnam, which is
Yes,
a
ma'am.
rural place. What is the cataract surgical rate over there?
Per week, they are doing 10 surgeries there.
What are the types of cataracts there? Mature cataracts or immature cataracts?
Mature cataracts and hypermature and immature senile
Why
cataracts.
still mature and hypermature? Is there no awareness in the public?
There, ma'am.
Why still mature and hypermature cataracts are there? Is there no awareness
Because-
among the
Yes,
people?
ma'am. There's lack of awareness, and they don't want surgery. They just need eye drops or any spectacle correction for that.
So
also.
many area hospitals are there now. So we have to increase the awareness.
Yes, ma'am.
And regarding corneal blindness also,
Yes,
we
ma'am.
have to educate them, they should not use own medications.
Yes.
Okay.
Okay. Thank you.
Well, Dr. Athili Leshini, I think she's going to talk about prevalence and practice of spectacle non-compliance in school children given spectacles in camps. Is she here? Dr. Athili, I think she's absent. So next one is Ankit Gupta. Is he here? Ankit Gupta. So finally we come down to actually one more, that is Raki. Dr. Raki. I think she's going to talk about the eye and tick-borne diseases, a study from the South India. What happened yesterday? You were absent or what? Fineness. Okay, that's good. Okay, that's good.
Good morning, everyone. Can I start? So I'm Dr.
Finalist from yesterday's talk.
So today I'm going to present my paper on the tick and eye diseases. So objective is to study the ocular manifestations and the complications following a tick bite. So I analyzed all the cases that presented to us with tick bite during the monsoon seasons in South India. All these patients were residents of Kerala. We did a detailed ocular evaluation, IOP, fundus evaluation, and all these patients were called up on frequent intervals to monitor for systemic manifestation. A liaison with a local physician and a microbiologist was created to refer, treat, and to follow up these patients. So the primary outcome was to study the ocular manifestations following tick bite, and the secondary outcome was to find the chances of development of systemic manifestations and also to find the efficacy of prophylactic antibiotics in preventing the complications. So we had 23 eyes of 23 patients, all were unilateral presentation. We found that the higher incidence is during monsoon season because it's their breeding season, and the best corrected visual acuity of our study population ranged from 2020 to 2000. The mean age was 47 years. Tick was present in situ in 13 eyes, and out of that it was live and still alive when we have taken out in 10 cases. Period of presentation after the tick bite was a mean of 4.9 days. Associated fever was present in 7 cases, and the mean period of development of fever was 7 days. Most common symptom was eyelid pain. Most common sign was eyelid edema. 10 patients attempted self-removal of the ticks. Non-granulomatous anterior uveitis was present in 5 cases, and the mean period of development of uveitis was 11 days. One case which presented like a conjunctival nodule actually had a dead tick embedded and concealed. This case had severe uveitis. Prophylactic antibiotics were taken in 16 eyes. 5 eyes which presented with uveitis and 4 cases which had retinal involvement actually had not taken antibiotics and were started later. One patient, a 78-year-old male, presented with uveitis, vitritis, and macular edema, actually had parts of the head recovered from the eyelid nodule with surrounding ulceration, and that was concealed. So these are some of the pictures of our patients, and 2 cases actually had severe cellulitis, but they were actually also having uncontrolled diabetes. Species identification was possible only in 11 eyes. The most common species was Ixodes in our case, but what we noticed was whenever it was dog tick, that is a dermacenter variant, almost always it led to fever. 4 cases had retinal findings, 2 had only disc edema, 2 had typical neuritis, retinitis like picture. They had also had associated myalgia and mild fever 2 days prior to the onset of the defective vision. Visual acuity had dropped to 20/60 in the first case and 20/100 in the second case. They were sent to the physician. He started them on tab doxycycline along with rifampicin and low-dose steroids. And the steroids were tapered very slowly. So ticks, as we know, are ectoparasites and then can cause serious and life-threatening diseases. Mostly these are reported from US and Europe, but it is not uncommon here. Actually, it is underreported. And why? Because it is because of the low clinical awareness and easily gets overlooked. Serological testing actually has a limited role because it can be negative in the initial few weeks. Hyaloma species and Haemaphysalis species are common in India. And why do these prefer the lids? They habitually enroute the meibomian gland and present like a mass that mimics a hemangioma or a nevus. And the preferential localization is due to the fondness of the tick to warm and moist environment, which is easily available in Kerala. And also, because of the eyelash that have cilia, they can easily travel to the lashes, and inhabitation leads to detection very impossible. And how it gets its bloody meal? It secretes some cementing substances and it releases anticoagulants through which it gets a continuous blood meal. So there are so many ocular manifestations possible, and how to remove. Whenever you are removing, you have to use a blunt medium tip forceps, otherwise they can release its potential infectious substances and can lead to complications. So to conclude, most common site in our cases was near the lashes, most common symptom was eyelid pain, and most common sign was eyelid edema. Incidence of systemic manifestation was less, but more with dog tick bite. Posterior segmentic involvement was less in our study population, maybe because almost everybody had taken prophylaxis, because in Kerala tick bite is very common and we have endemic diseases. And it advisable, so we advise it is better to start at a prophylactic doxycycline in all cases, since the chance of development or complication is still unpredictable. Thank you. And here I will show, I wanted to show that tick. Okay, can I show it?
It inhabits lid, na? Why
Yes.
it is involving posterior segment?
Sir, madam, it is because of the Lyme's disease. The ticks carries the vector Borrelia burgdorferi, and when it, if the Borrelia carein has already got it entry into the patient, it leads to Lyme's disease. So a Lyme's disease usually presents with neuroretinitis and papillitis.
Because of Lyme's disease, it is.
Yes, ma'am. Ma'am, this one is my favorite.
Not because of tick bite, because of Lyme's disease.
Yeah, yeah. Tick is a vector to many diseases, ma'am, and Lyme's disease is reported many in Kerala. So this tick was actually removed after 10 days. It was very nicely concealed. You can see after 10 days also it is running in a race. It was very fast, still alive.
Very interesting.
Thank you, sir.
Where is the slide? We should present the slide also.
So people who were absent, one is Lihalin Chowdhury. Is she here? Athili. Okay. Next. Ankit Gupta. So I think this is over.